So I'm going to go ahead and share my screen and we're going to get started. And it's just thrilling if everything goes the way that it's supposed to go. Because I know sometimes technology works well, only when it works. And sometimes there are some glitches, but hopefully. Yeah, so if everybody can put themselves on mute, that would be great. Because I'm hearing some music in the background. Okay, so what I'm going to do is go ahead and mute everybody so we don't have that background noise. And if you do need to unmute yourself to ask a question, absolutely feel free to do that. So we're going to go ahead and start the webinar, which is on cultural competency and health education, a window of opportunity. And I am the presenter. My name is Dr. Gayle Walter, and this is Iowa Sophie's first webinar in our Lunch and Learn series. So just a little bit about me. I am a lecturer in the Department of Health and Human Physiology at the University of Iowa, and I teach undergraduate students both in the health promotion track and also in the health studies track. And I earned both my PhD and my MPH from Walden University, so I obtained both of those online, which was quite challenging, but I managed to get it done. And both of those degrees have an emphasis in community health promotion and education. I am also CHEST certified and have a wide variety of research interests in global health, the determinants of health, health equity, as well as healthcare reform. And I wanted to provide my contact information just in case if you do want to get a set of the PowerPoint slides, you are more than welcome to contact me. And also, if you'd like some additional information about Iowa Sophie or the presentation today, absolutely feel free to reach out to me as well. So the objectives for today's webinar then is after the conclusion, you will be able to explain the importance of cultural and linguistic competence in health promotion, identify ways to integrate cultural and linguistic competence into health promotion programs, and also to discuss strategies to promote cultural competency in working effectively with individuals or communities served by your organization. I got ahead of myself there. Okay, going back to the first slide, just to provide just some very general information regarding cultural and linguistic competence. We know that it is absolutely needed because of the racial and ethnic diversification of the United States population. It does establish the need for cultural and linguistic competence. And it pretty much goes without saying that in order for these health promotion programs to be effective, health education and prevention strategies absolutely must address each group's unique culture, experiences, language, age, gender, and sexual orientation, and be culturally and linguistically appropriate. And we all know that even though there are several different unique cultures that make up the population of the United States, just because one health promotion program is able to be effective in a certain setting within this culture, it doesn't mean that it's going to be generalizable to that same culture, just because there are so many different variables that need to be considered. This next slide just basically provides a snapshot of our expected population increase from 2014 through 2060. And this was taken from the US Census Bureau with their 2014 national projections. And I've looked at a lot of different sources related to our population increases, and basically they are all saying the same thing, that yes, our population is definitely going to be increasing by the year 2060, and is also going to be made up of a lot of foreign-born individuals, further contributing to the increased diversity within the population in the United States. So take note then on that last column of the foreign-born proportion, which is projected to be almost at 78.2 million persons by the year of 2060. So it's really important for those in health education or those in public health and basically within the healthcare system itself that we are proactive and we're already assessing our cultural competency and being proactive and making sure that we are going to be able to meet the needs of this increasing population. So the population is expected to increase from just under 319 million to just under 417 million in the year 2060. So when we look at consideration for health promotion and health promotion interventions, the increasing racial and ethnic diversification makes it essential to incorporate cultural and linguistic competence into every single aspect of health promotion planning, which includes the planning, implementation, evaluation, and also the dissemination that I think we sometimes tend to forget about. But when you are planning and you are considering cultural competency, in the planning stage, absolutely, your target population, invite them to the table. It's great to read information from the community needs assessment, and it's great to conduct surveys and all these different types of things. But in my opinion, the best way is if you want to get information about a certain population, you just simply ask them. Invite them to the table and ask them about their concerns and their priorities and what type of interventions would work best for them based on the resources that they have, based on the environment that they live in, and also a lot of the social support also makes a difference as well. And in the implementation stage, when you are implementing your health promotion program, definitely you want to make sure that all of your materials, all of your communications are available in the target language of your population. And I've come to discover that just because you simply maybe translate a document in English to a different language, sometimes it really doesn't get translated accurately, or it kind of misses some of the context of the meaning of the information. So it's a really good idea to have members of your target population also pilot test the materials. Ask them to come in if there's maybe like a certain work group or a task force that you're working with. Just say, hey, would you mind coming in and just reading these materials for sense, making sure that you can understand them, and once you understand them, that you could actually take what that information is saying and apply it as well. The next part is the evaluation, where all of your evaluation, your post surveys or your questionnaires, those should also be in the target language as well. And too often, we also do forget about the dissemination portion of it, but it is equally important because the people that are especially representing these target populations or are a part of these target populations, they want to see the benefit that intervention is doing within their communities. And if they can see the benefit and they understand that it is cultural and linguistic competent, that they more be likely to then want to participate in this intervention, making it even much more successful. So don't forget about that part where you want to really, really share the great things that you've done with your community partners and also members of that target population. But of course, first things first, in order for all of this to happen, we do need to make sure that it begins with having a workforce in place that is capable of providing these services. So when we talk about cultural and linguistic competence, as you know, healthy people, the goals of healthy people have evolved in the past 10 or 20 years. And one of the 4 goals of Healthy People 2020 then was to achieve health equity, eliminate disparities, and improve health of all groups. And we all know, no matter if you're in public health, you're in healthcare, you're in health promotion, we know that disparities exist. And there's also significant disparities between non-whites in the US compared to their non-Hispanic white counterparts. And they are caused by, a lot of different factors. The first one is having a lack of health information, where maybe certain populations are having a difficult time navigating the health system, and they're not really sure who to go to, who is the appropriate provider. Are these symptoms considered to be severe, or should I just kind of wait it out and hoping that they'll go away? And then by the time that they do go see their provider, the symptoms have really escalated, and have become quite severe. So that health information and that health literacy is a big part of contributing to these disparities, these health disparities. Lack of health insurance. The Affordable Care Act was wonderful in making sure that people had access or were able to purchase health insurance through the exchanges, and also with the expansion of Medicaid. But as we now know, the individual mandate has now been removed. So, people are not required as of 2019 to purchase health insurance. So that individual mandate has been removed. But hopefully, that's not going to create too much of a decrease in the number of people who are still wanting and able to purchase insurance. The next thing is individuals' beliefs and attitudes, and that is about accessing healthcare. Kind of what I alluded to when talking about health information, that their beliefs and attitude, what constitutes going to the doctor, what type of symptoms should I have, should I go to, what is it going to cost me, what is my copay? A lot of those things really make a difference. And sometimes I think we've all been in this position where if we're just being bombarded with all of these different things, or maybe even not having access to a lot of different things, sometimes we just don't know what to do, so we simply do nothing. And that's absolutely what we don't want to see happen. Another contributor is the shortage of diverse healthcare providers. And there's not enough healthcare providers that a lot of cultures or a lot of ethnicities and races they're not comfortable in going to see. So we need to have that diversity within our healthcare system and also within health promotion. And that could be, if we're kind of brainstorming and thinking about different ways, well, how are we going to entice or how are we going to encourage these racial and ethnic minorities to want to become nurse practitioners or PAs or physicians, that maybe there needs to be some type of incentive in place where, these people are much more willing then to go into medical school to have then that diversity in healthcare providers. We're also seeing a lot of comorbidities involving other serious health problems. And that is in, relationship to, diabetes, obesity, heart disease, that once a person becomes obese, then therefore it can lend itself to a whole lot of other different comorbidities. And poverty, I think, is probably one of the main determinants that lead to health disparities. Because if you're living in poverty, you may not have access to health insurance. You might be kind of falling right in that middle ground where you can afford your health insurance premium, but then you make too much to be on Medicaid. So it's kind of, you're kind of stuck in that middle gray area. And also, when we think of poverty and the social determinants of health, we're all, looking at employment or education or housing or the built neighborhood. All of these different types of determinants are also absolutely increasing to health disparities. And if we kind of go back up and look at that goal of Healthy People 2020, where it talks about eliminating disparities, in a perfect world, that would be absolutely wonderful if we could eliminate those. But I think we all know that rarely is there just one single cause? You know, there are a lot of different causes. So basically, we have to eliminate all of those and to eliminate disparities. And definitely, we are making progress, that is for sure, but there is still a whole lot more that needs to be done. So these are 6 reasons that were suggested by the National Center for Cultural Competence. And I don't know if you can see this on your computers when you're looking at the slideshow, but I do have all the references down at the bottom of the slides. And I also have a references list at the end of the PowerPoint presentation if you wanted to take a little bit more in-depth look at some of the references I used and the information that they do have about the content that is listed on the slides. But cultural and linguistic competence absolutely plays a significant role in decreasing health disparities. And according to the National Center for Cultural Competence, they made these 6 suggestions to address and decrease health disparities. And they were pretty much designed for healthcare specifically, but they are, of course, applicable to health education and health promotion as well. And the first reason that we need to have cultural and linguistic competence is to, as I talked about earlier in the presentation, is to respond to those current and projected demographic changes. You know, multiple sources, every single source that I've looked at are projecting to have significant population increases, especially in racial and ethnic minorities. The second one on the right there is then to eliminate long-standing disparities in the health status of people. And this is of people in diverse racial, ethnic, and cultural backgrounds. And as I mentioned, there has been progress, but a lot more work needs to be done. And that could be simply just having the support and resources and funding available from the federal government to kind of implement some of these strategies that we have to eliminate those long-standing disparities. Second one, or the third one then, is to improve the quality of services and health outcomes. And this can happen by practitioners having a really deep understanding of sociocultural backgrounds of their patients. And this could simply be not looking at just the patient themselves and the symptoms that they're presenting, but we also really need to look at the patient or the client or the customer from a more holistic approach and not be recommending something that may not be feasible. So we have to consider then, you know, what type of environment are they living in? You know, it's not very wise to suggest physical activity for somebody who may be borderline obese if they really do not have the environment to participate in physical activity or those lack of resources. So we really have to think of the person holistically, their environment, what resources that they have available to them, and also their social support and who's going to help them in their quest for better health. The fourth one then is to meet legislative, regulatory, and accreditation mandates. And a couple of these that stand out is Title VI of the Civil Rights Act. It is stating that no person should be denied benefits or be subjected to discrimination under any program or activity receiving federal financial assistance. So we need to do this by law, that we have to make sure that we're meeting the needs of diverse populations. The national CLAS standards is something that we're going to be talking about in the next couple of slides, and also the Plain Writing Act of 2010. And that act, if you're not familiar with it, it was signed into law in 2010. And what it states that is all federal agencies, not government agencies, but these are federal agencies, need to use clear communication that public can understand and use. So if you go to the CDC website or Medicare or Medicaid or any of these federal agencies, they have to have their information available to make it easy for people to understand. and also for people to be able to use that information to make then informed choices about their health care. And I actually went and looked just for fun because I'm like, oh, let's see what these sites, have on there in relationship to the Plain Writing Act of 2010. And yes, definitely, there is some information on there that they do ask if you don't understand the information or you want to talk with somebody to get further explanation, those services are available. So I think, that's a great start. But these things then are mandated. And there's a lot of different accrediting agencies, such as the Joint Commission, that do support these standards. The fifth one then is to gain a competitive edge in the marketplace. And as you well know, healthcare is a business. It's very, very competitive, and there is a real push for consumers to be engaged within their healthcare and making decisions. So if you are if you are already practicing cultural and linguistic competence in the services that you're providing, you are absolutely going to have that competitive edge in the marketplaces over others that maybe not being proactive and not providing some of these services available that they should be. And lastly, why we need to have cultural and linguistic competence is to decrease the likelihood of malpractice claims. And, when I first kind of did some research for this webinar, I really didn't even, the thought of health promotion and health education and the thought of malpractice really didn't, wasn't the first thing that I was thinking about. But, after looking at those mandates that need to be in place, if you are not respecting patient autonomy, you are maybe providing, recommendations that you think that the patient should do or your customer should do, and not really allowing them to have autonomy or a choice, that is definitely an infringement of patient autonomy and the patient's Bill of Rights, and also not being able to address health literacy. So technically, if things didn't go as well, or if the patient or the customer or the client felt that their rights were being respected or their autonomy wasn't being respected, that could be the grounds for some type of malpractice. So it's just kind of something that you want to keep in the back of your mind. So let's go then back to cultural competence. And I'm not sure if you are familiar with the continuum of cultural competency that I have down here on the bottom of the slide. But first thing I want to do is define cultural competence. And depending on which source you look at, it's all kind of defined a little bit differently, depending what source that you look at. But for the most part, the working definition that I'm going to use is the ability of the individual to understand and respect values, attitudes, and beliefs that do differ across cultures, and to consider and respond appropriately to these differences in planning, implementing, and evaluating health education and health promotion programs and interventions. So the first thing, if you haven't done this, I would definitely encourage you to do this. But first thing, just from a personal standpoint, to somewhat do a self-assessment of your own um, um, knowledge of cultural competency. It's just kind of see where you fall along this continuum. And it goes from the far left of cultural destructiveness to the far right of cultural proficiency. And if we look at cultural destructiveness, as you see here, it talks about forced assimilation, subjugation rights and privileges for dominant groups only. So basically what this is saying is you are using one's power to pretty much eliminate the culture of another person, to eliminate the culture of another, that they simply do not exist, or they are not worthy of existence and their opinions do not matter. So that is on the far left or the far low end of the spectrum. Next, we move on to cultural incapacity, where that is characterized by racism, stereotyping and unfair hiring practices. One of the things that I think is really, really important is that when you are working with different cultural groups, racial, ethnics, and minorities, is that you do not stereotype. Because even though they may be from within a certain culture, even within that culture, there are many, many different varying practices and beliefs. So one thing I would absolutely encourage you to do is to not stereotype. Um, and this would, sometimes it's easy to do, but we have to refrain from doing that. And in cultural incapacity, basically, we've got lowered expectations of the other culture that, you know, their opinion doesn't matter as much. They don't have a powerful of voice as the dominant culture, and they're just not really, they don't have the capacity to make decisions and be a part of the discussion. We next move on to cultural blindness, which basically means that we really don't recognize the different cultures, that everybody gets treated the same. But unfortunately, when we're treating everybody the same, we're only meeting the needs of the dominant group. And as you know, even in the dominant groups and within racial and ethnic minorities, granted, we want to treat everybody the same as far as health equity, but it's impossible to treat everybody the same because everybody's got different needs and wants and values and beliefs, and we really need to be respectful of that. And then next we move on to cultural pre-competence, where now we're starting to explore cultural issues and we are committed. We're then starting to assess the needs of the organization and also of individuals. So if you are in an administrative position within your work, or in a position where you are making decisions regarding the structure of the organization and the policies and the practices, then this is where you kind of start thinking about, well, what can we do in our organization to make sure that we are practicing cultural competence? And then we kind of move on to then where we're getting to that stage where we're recognizing individual and cultural differences, where we're seeking advice from people within those diverse groups. We're also hiring staff members in order to promote a more culturally diverse workplace. We're starting to advocate for other cultures as well as educating others as well. And then the far end of the spectrum then is actually when we are culturally proficient in our workplace or in our organization or in our hospital or in our public health department. We now have cultural competency that is actually ingrained within our services and also within a lot of the policies that we have within our organization. So definitely, I would advise all of you, if you're not familiar with this and you maybe want to take it back and show it to others within their workplace. But I think it's really good that we complete a self-assessment just to kind of see where we are with our own knowledge and familiarity with cultural competency. And even if we're maybe falling, at the further left of the spectrum, then at least we know that we're there, and we can take those measures then to become more informed. So in addition, the process for cultural competence, and this is kind of looking more from an organizational standpoint, and because beyond the individual, we also need to consider the organization as a whole and where it does fit along that continuum. So the National Center for Cultural Competence also has suggested these guiding values and principles, that there has to be a defined set of values and principles that demonstrate behaviors, attitudes, policies, and structures that enable them to work cross-culturally. So maybe this is something where, you can kind of take this information back into your workplaces. And if you really don't have any policies on cultural competency or any practices or any type of education or professional development that's related to cultural competency, maybe this is where you can start working on that, or maybe putting it into your strategic plan for the next 5 years, that you are going to work on those these things. So you can move then far along to the right-hand side of that continuum. Organizations also has to have the capacity to value diversity, to conduct that self-assessment that we've talked about, as well as manage the dynamics of the difference. So if you do have, it doesn't even have to be from staff to customer to client. This could also be between staff members or between employees where you might have some clashing with cultural differences. So if you are seeing a clash between people that are working in your organization, what are you going to do to solve that, or what are you going to do to address that? And that also has to be managing the dynamics then of those differences. Acquire and institutionalize cultural knowledge. Absolutely, you want to make sure maybe as part of every, new hire, as part of their orientation, that they're mandated to take a course in cultural competency or diversity, just to make sure that they do have some type of knowledge. Like I said, it's impossible to know everything about every single culture that's out there. But one thing we have to, be competent in is to realize that there is a difference and to acknowledge those differences and make sure that we're providing those specific services to respect diversity. And then fifth, we need to adapt to diversity and cultural contexts of the communities that we serve. So all of these then, incorporating all of the above, should be included in all aspects of policy making, in administrative decisions and administrative practices, service delivery, and systematically involving consumers, key stakeholders, and communities within those decisions. So even if you are working in a community that has a higher percentage of racial and ethnic minorities that make up your population, get in touch with those people that are already maybe working with them already, and that could be, if you have an area agency on aging, if you have a certain organization that are working with refugee populations or immigrants, reach out to them, absolutely, and kind of bridge that gap, and I'll kind of work together to make sure that you're providing these culturally and linguistic competence services. So now as we move on to linguistic competence, which really isn't talked about so much as cultural competence, but absolutely just as important. But health educators also need to be made aware of the complexity of linguistic competence. And basically what it is then is the capacity of the organization and its personnel to communicate effectively and convey information in a manner that is easily understood by diverse audiences. And, easier said than done, but fortunately, there are a lot of different strategies that are available to accomplish proper communication with diverse audiences. And I'm going to talk about a lot of the strategies in the following slide. But linguistic competence then requires individuals and organizations, they have the capacity. And that's one really important word that I want to stress, is having that capacity. So it may have to be where administration or upper level management needs to, when they're looking at the budget and they're thinking, yeah, on our strategic plan, we really want to put these things in place in order for us to be a culturally competent workforce, that maybe there has to be some additional funds that are dedicated within the budget to take care of some of these things. So having the capacity is the way that you're going to be able to fulfill a lot of these things that you want to accomplish, because you need to make sure you're responding effectively to the health literacy needs of the populations that you serve, not necessarily limiting it to racial and ethnic minorities, but making sure that that's available to all persons. And these are some of the strategies that I was talking about just a few minutes ago that may help you to become more linguistic competent. And the first one would be having a bilingual and bicultural staff, or actually it could be multilingual or multicultural staff. And this is not only the health educators or the staff that may be working directly with the patients or the clients or the customers, but this is also, if you think about it, your receptionist or the person in the waiting area that is the first person that greets that individual. They are sometimes just as important because they are the first face when they walk in the door, and that will maybe kind of make or break whether they feel that this is a welcoming atmosphere for them. Next thing, cross-cultural communication approaches, and that involves a lot of different ways in how different cultures communicate. And the best way to know the right ways to communicate is to learn a little bit more about your target population, how they would like to be communicated. It could be verbally, it could be through the written word, it could be through the use of pictures and with maybe minimal words. So you really have to determine the best way that your target population likes to communicate. And then also consider interpretation services. And when we first look at this, sometimes we kind of think about, oh, we just need to translate from English to another language. And unfortunately, it's not really that simple. In addition to foreign language interpretation, we also need to make sure that distant technologies are addressing that as well. So for example, if you're working with racial and ethnic minorities who English may not be their first language, and maybe you're engaging in telehealth or telemedicine or some other things where you're working, with that patient at a distance, you need to make sure that you have an interpreter available possibly at both ends when you're communicating with that patient. Another thing to also consider is sign language, to make sure that you have someone available to perform sign language. And one thing to remember is sometimes simply translating English to another language does not get the message across, that you really need to maybe consider some of the other contextual information within that message to make sure that it's being understood. Another strategy then is to use multilingual telecommunication systems. So this has to do a lot with your reminder calls, or if you do have some type of patient portal, or if you're encouraging these diverse populations to possibly sign up for your intervention or your program online, that if they access that website, that there's going to be information there where they know how to sign up, that that information is maybe available in a different language. So they know how to sign up, they know where to sign up, and they're able then to sign up for that intervention. Text messaging is used quite a bit for reminders and also for a lot of interventions where you can simply send out a text message. Did you brush your teeth today? Did you get your steps in today? All of that has to be within the language of your target population, because if they don't understand it, they're probably not going to be compliant and your program is going to be less successful. And then the fifth one then is materials and ethnic media in languages other than English. So this has a lot to do with health communications. So your PSAs, your television ads, maybe you're taking an ad out in the local newspaper, the radios, billboards, all of those have to also be created in the language of your target population. And a great thing, as with, we kind of go way back to the beginning of the webinar when we're looking at, just get people within your target population to come in and say, would you mind listening to this PSA? Would you mind taking a look at our idea that we have for a billboard? Does it make sense to you? And based on what you've read, what would be your reaction to it, and what type of action would you take as a result of that? That's an absolutely best way to get some feedback to make sure that your health communication materials are, indeed effective. So one thing that really hasn't been talked about a lot, but since what I wanted to mention is working effectively with an interpreter. And interpreters are used a lot. And one thing I wanted to bring to your attention that sometimes because we don't have a trained interpreter available, maybe it's in an emergent type of setting where we have a family member or we have one of the children that are interpreting for the patient, between the patient and the provider, it's probably best to avoid that. And in this situation, when you are working in health promotion and you're working with a client and you've got time to kind of plan ahead for your visit with that client, it's always best to use a trained interpreter. And these are just kind of some suggestions that Think Cultural Health has recommended that you should do before your visit with a patient or client who needs an interpreter. So you don't want to be rushed through your appointment or rushed through your time with that client. So make sure if you're scheduling different clients throughout the day that if you know that you're going to have an interpreter that you take and allow some extra time for the visit to take place, since you may be having to communicate your information at least twice. And you don't want to rush through it. You don't want to talk quickly because you're pressed for time. So make sure that you are allowing some extra time. And you're meeting in an environment without any distractions or with minimal distractions. Because if they're having a difficult time understanding the information, you want to make sure that there's no outside distractions and you can have a meaningful conversation. Another suggestion would be to consider learning just some basic words from the target language. It's very difficult to be fluent in all the different types of languages that exist, but if you know that you're meeting with somebody and this is their target language, learn just a simple words like hello or goodbye or thank you. And that would really mean a lot that to that person that you're taking the time to want to learn about them and want to learn about their language. So not to be fluent, but at least just know a couple of basic words from their target language. And before you meet, you should also give the interpreter a brief summary about the individual and discuss goals and procedures for the session. Because that way you don't have to have these communications between each other, between the health educator and the interpreter, that those things are already kind of taken care of ahead of time so the focus can then be on the individual client. And next, during the visit, these are some recommendations. So introductions should be made directly to the patient or to the client. Don't treat or talk about the patient about them. They're in the room next to you, so everything should be made directly to the patient, and use first person and ask the interpreter to do the same. Another thing to remember is to face the patient and speak directly to him or her. Do not face the interpreter like you're using that person to relay to the individual. Basically, you want to be speaking to that individual client and make them feel like they are the focal point of that conversation. And if you notice, during your conversation, it's always good practice to observe and monitor your patient's nonverbal communication, because you might see where you know, the patient or the client, maybe they're starting to get fidgety, or maybe you can just tell by the look on their face that they're maybe not understanding the information that is being relayed to them. So that might be a time where you might need to kind of step back and ask questions to make sure that they're understanding what you're trying to say. And you could also maybe ask them, kind of do the teach back and maybe ask them um, what was just stated and if they do have any questions. Speak slowly and clearly, use very simple language, no medical jargon, and that's not only for the client's sake, but that's also for the interpreter, because a trained interpreter, unless they have medical expertise and they're familiar with medical jargon, they're not going to know what that means as well. So refrain from using any type of medical jargon whatsoever. Best practice is to use sentence-by-sentence interpretation. That generally works the best. And if you do notice that the patient or the client, maybe has a confused look on their face, or, rather than nodding in agreement, they're just not making any type of acknowledgement of what you're saying, ask the interpreter to ask open-ended questions if additional clarification is needed. And lastly, some important things to remember, and you don't want to get yourself in trouble with this, but some individuals who require an interpreter may actually understand English quite well. So don't assume that they don't know any English and you're making comments to the interpreter or making comments under your breath or as you're writing down some notes that that patient or that client can understand those. That would not be very good. So don't don't assume that they don't understand English, because they may understand it quite well. And if a patient refuses to use the language assistance that you offer, ask him or her to sign a form stating that language assistance was available and he or she chooses to decline those services. That form should be signed or created and then signed in the patient's native language. And that kind of goes back to those standards and those mandates that we had talked about earlier in the presentation, that if you are receiving any type of federal funding or any type of federal assistance, you have to make sure that language assistance is made available to all persons, that they know it's available, you've explained that to them, but if they do refuse those services, that has to be documented. And oh my goodness, kind of getting a little short on time, so we'll just kind of go through these last few slides and hopefully we'll have some time to ask additional questions. But the national CLAS standards, you should be familiar with those. And basically what these are is just a collective set of mandates and guidelines that inform recommended practices related to culturally and linguistically appropriate health services. They were developed in 2000 by the Office of Minority Health, and then again were updated in 2013. And I'm not going to go through all of the standards. There are, let's see here, there's about 15 different standards, but basically the principal standards is to provide effective, equitable, understandable, and respectful quality care and services. And if you look, they're kind of separated out into three major categories. If you are in administration or if you are in upper level management, you're absolutely going to want to be familiar with standards number 2 through 4 that talks about governance, leadership, and workforce. If you are a health educator and you are working directly with your clients, you absolutely want to be familiar with standards 5 through 8. This is probably the most important ones. And this is not only applicable to health educators, but also public health nurses and anybody within your department who has direct contact with clients. And then standards 9 through 15. This is again then for administration and upper level management to make sure that you have your employees that are engaged in cultural competency. There are methods in place for continuous improvement and also accountability. I'm going to go through these kind of quickly just for sake of time, but you can go ahead and just Google those national CLAS standards and you'll be able to see all of these and then have them explained in a little bit more detail. And I want to finish up with just some strategies on how to incorporate cultural and linguistic competence into health education. These are 6 strategies that may be very, very helpful for you when you are working with racial and ethnic minorities or any type of diverse populations. First thing is that health educators must learn to recognize the importance of culture and respect diversity. Because as you know, culture influences many areas of our lives, the communities we live in, our families, as well as how we operate in society, and a lot of different factors come into play here. So it's really important when we kind of get back to that training and that education element that health educators learn and recognize the importance of culture. Second one is to maintain a current profile of the cultural composition of the community. And that can be done simply through accessing the community health needs assessment and also stay connected with those organizations that are working directly with these populations. Thirdly, provide ongoing cultural and linguistic competence training to health educators and other staff. As I mentioned earlier, being culturally competent, it's a process. It's not an endpoint where once you learn about it, you're done. It's an ongoing process that takes a long time. And especially if within your communities, maybe there's an influx of immigrants or refugees that are coming into your community, then it might be then again time to learn a little bit more about that population. Involve cultural brokers from the targeted racial and ethnic groups. And a cultural broker is basically a community leader or any type of organization that's representing those diverse groups where they can kind of serve as a bridge between those populations and the local public health departments or whatever entity would be interacting with them. It's great to just kind of have that bridge or that liaison between those two different segments. Number 5, ensure that health education programs and services are culturally and linguistically appropriate, and that would definitely include your written materials as well. And then make sure you're assessing and evaluating the program's level of cultural and linguistic competence. And that can be through a lot of different self-assessment tools that are available. I've provided just a snapshot of some of the tools that are available through the National Center for Cultural Competence. I think I just picked out about 4 of them, but there's probably about 25. So if you want to evaluate the cultural competency of both your workforce and your health intervention programs, lots of different tools that you can choose from. And kind of separating out some of these standards, but these standards were proposed by Perez and Luquist based on extensive review of the literature, their work experience, and also their personal experiences. And what they are suggesting, some standards that should be in place to make sure there is cultural and linguistic competence in health education is absolutely to have that trained workforce, where all professional preparation programs in health education must offer cultural competence courses. I teach, like as I mentioned, 4 different classes at the University of Iowa, and I put cultural competency into all of them just because if people are going on or if students are going into the field of health promotion or they're matriculating onto graduate school to become physicians or nurses, they absolutely have to have that professional preparation. And also to have continuing education for practitioners. And when referring to health education programs, use those assessment tools that I just provided you a snapshot of. Make sure they are appropriate for the type of information that you are wanting and the type of health promotion program that you're evaluating. Make sure you are working and including members of that target group, and at all times, if possible, use the targeted group preferred language. And another strategy would be to empower racial and ethnic and cultural communities. And that's kind of when we go back to that continuum, where we get to that level of cultural competencies, where we're advocating and we're asking them to be a part of the process. And then ensure all of your programs are accessible, appropriate, and equitable to all persons. So as we're wrapping up here, just some key points to remember is that health educators need to understand that cultural and linguistic competence are an integral part of the development, implementation, and evaluation of health education and health promotion programs. And as I mentioned earlier in the presentation as well, also have it be a part of your dissemination as well. And health educators also need to promote cultural and linguistic competence in order to work effectively with the individuals or communities served by their organizations and also to address their health needs as well. So as we wrap up here, I know we're kind of limited on time and I apologize for that, but I'm going to go ahead and see if there's any questions, and I'm going to see if I can go back to stop sharing the slide so I can see your questions on the right-hand side. Looks like we have quite a few. So I'm going to go ahead and unmute all of you, and if you want to go ahead and be muted again, you are more welcome to do that. But do you have any questions or any comments that you want to make? I'm going to try to see if I can get back to the thing where if you're typing in your question, then I'm able to see that. But any comments or any questions or anything that you want to add to the presentation today? No questions. Okay, well, we're going to go back. I just want to show you before we end here that there will be some future webinars that will be held by Iowa Sophie. The next one will be a holistic approach to health education, and that will be presented by Emily Harbacheck, who is also the chair of our continuing education committee. And we also have another webinar coming up possibly in November, which will be on program evaluation. And as you know, this presentation has been approved for one CHES CEU. If you are a member of Iowa Sophie, that continuing education credit is free, and we can go ahead and process the paperwork for you, but we do need to have an email address. And also, we are going to be hosting 3 of these a year, and all of them we will be applying for CHES credit. So this might be a really opportune time for you to go ahead and possibly consider joining Iowa Sophie. And I have our web page there as also as our Facebook page, and we would be delighted to have you as a member. And for additional information, this is the contact number or the contact email for Iowa Sophie. And if you would, excuse me, if you would like, my apologies, I almost made it through the webinar. And if you would like, again, more information, my apologies. If you would like more information or you would like information about how to obtain your one CHES credit, please feel free to send an email to that email address at sophieiowa@gmail.com. And just to be cognizant of time, it is 1 o'clock, and I just want to thank you very, very much for attending this webinar today on cultural competency and health education, a window of opportunity. And thank you so much for your time, and all of you have a great day.